keep on saying is that we cannot talk about healthcare service delivery or universal healthcare without investing in that healthcare. We must prioritize a budget for healthcare, both from national government and in the county government. And the moment we don't do that, you will see the political leaders not consuming that healthcare that themselves are leading. You'll see governors, you'll see the MPs, you'll see the ministers having very hefty medical insurances that then guarantee them access to healthcare outside the country. And therefore, whether this healthcare is dysfunctional, it will not be an issue that affects them. So yes, a policy that ensures all of us have this access to the public healthcare that we provide will, in a way, ensure that that it works. Number two, the issue of cartels or corruption is rampant. In fact, at one point, we were seeing that devolving healthcare is in a way was devolving in corruption. Because we have those who are just in charge of procurement and they're looking at how much are they getting from kickbacks within the counties, and the same thing within the ministries. I remember when the minister came into office and he was being asked whether there are cartels, whether Mafia House is a mafia house, and he said no, it's a mafia house. But 1-2 months down the line, he's saying no, he has seen so much cartels in the ministry that it's a mafia house. Even this issue of UHC that is being talked about now, where the ministry talks about 8,700, while the counties talk about 5,700, meaning there's 3,000 difference. You know how much that totals to? It's millions of shillings.
Yes.
So ideally, when such things are raised, there should be investigations. There's things need to be put in a proper way so that this money can be put in the right use for the public.
But whose responsibility is it to kick that into place?
The responsibility must be for all of us. I mean, if you can't put aspersions on one side. The ministry must be responsible for any corruption that takes place there. The leaders and the unions and the workers must also be responsible for this. And therefore, if it happens within the working facilities, they must raise the alarm over this matter. And these people must be brought to book. You know, most of the time, I find the issues of corruptions and the issues of pilferage of funds to be just a propaganda thing. Like you just talk about it, the media raise it up the way the former ministers used to do, and nothing is done. For example, in the NHIF that they are bring about, the government has all mechanisms that if there are people who are involved in financial pilferage or in corruptions or in these deals, they can be brought to book up to the right point of it.
Daktari, what will it take for this push and pull, for this endless fight between national government, county government, and the health in the healthcare sector to finally come to an end, and for healthcare to finally be given the priority it deserves? Because the patients out there are tired of the back and forth over and over again. What will it take for people to sit on the table and say, this is the way we want to go and we must do it?
You know, we must be, as Kenyans, ready to hold our government leaders accountable, the politicians that are elected in office. Because, you see, the Constitution outlines it very clearly in Article 43, that healthcare is a right of all Kenyans, and that the emergency care, you need to be able to get it anywhere else, anywhere we go to it. So if, for example, government tells us that we are going to get these services within a county government facility, you go there and don't get the care, you need to ask, why is that the situation? You need not to leave these things for only the healthcare workers, the unions. The public must have awareness and must be able to put the leaders who are elected in the office to account from the MCAs. Because when you go to a facility and you don't get the drugs, or you don't get an healthcare worker, or you don't get the equipment that you need, then you should ask the MCA from your region, what is his role in the county assembly? We need to ask the members of parliament that what is their role in the budget that they are doing. We need to ask the government, then what is the UHC that you're going to give us when we have to sell our lands and properties to access care?
In your opinion, is there political goodwill in ensuring that these issues are sorted out once and for all?
Political goodwill is forced, and it's not always given, because most of the times, if you stay put and ask and wait for it, it will never happen, because at any time that healthcare is not functional, somebody is benefiting. When public healthcare doesn't work, it means that those who have invested in private sector are benefiting and are reaping more. And therefore, when we come out and speak about these things, then changes come. I believe to now that the changes that took place in the Ministry of Health were not a mere thing that happened because there was no reactions from Kenyans. We saw all Kenyans coming out and say social health authority is not working. We saw Kenyans coming out and saying that the issue of the UHC is a pipe dream and it's rhetoric. We need a change. And then the ministers that were there, the leaders that were there, were always saying things are okay. While they were saying that you will go to oncology clinic and top up money to get care, you will go to the to the ICU and top up. But I'm saying this leadership who are there now are coming for a change because of one reason. When the cabinet secretary Duale came into office, we had a concern and we had done a press regarding the ICU package where it was 4,000. It was increased to 28,000. We had talked about the chronic oncology cases where it was 300,000. 300,000 means that you will get, let's say you are on Zoladex as a drug.
Yeah.
You'll get 3 months, then use for your partner another 3 months. So it means you will have 6 months of the drug. We were concerned about that, and it was raised to 550,000 for each for every cycle.
Okay.
And then another, your partner also 550. Then they went as far as having an agreement now with Roche, where instead of this drug going for 120,000, it's now at 40,000. So it means that if you have your package, you can go the full circle without having to add more funds.
More money.
Yes, and I think that's why the noise about social authority has gone down, because of those interventions. We have seen the board went ahead to hire a new CEO to that office. I believe social authority is working, but there's still more changes that need to be done, particularly those that goes with the co-payment of services, whereby some hospitals will desire then to charge you fund beyond what has been prescribed in the benefit package. But also this change that we have seen recently, a benefit package team has been put in place in charge with Professor Jahoko. This tells you that yes, the noise, the concerns of the Kenyans did not go into deaf ears. There's something that's being done. There's something that actually can make us have that access we need. But then it has to be progressive. We must keep on engaging. We must keep on bringing these matters, because that is the only way that these people will see. Because most of them don't consume the same services that they're offering.
Let's talk about ethical concerns.
Yes.
I know you've been on record and you raised an alarm over the recruitment of over 1,500, something like that, of foreign medical practitioners in the country. And I think in one of your statements you said these people are basically coming and there's potential human organ trafficking. I don't know whether there was any evidence to that statement. And in part two of that question is, what then should be actioned as a regulation to address these concerns of bringing in then foreigners who are coming to practice?
Yeah, our statement on the issue of foreigner was backed up by data. We did actual research to try to investigate the number of foreign doctors that have been registered by the Kenya Medical Practitioners and Dentists Councils within a period of 6 years, and realized there was a big number that has been registered, over 1,500. And then we looked at what are the numbers of doctors who have also trained over the same period that then are not employed. Then we saw that there was a big number at the same point. And then we checked what necessitated the importation of a medical officer, who then we have those who have graduated from Kenya. Then the council told us that their role is just to register. As long as you've come and you meet all the documentations, they'll just issue a license. And most of the license issuance was initiated by private hospitals that wanted cheap labor from these foreign doctors. So they will go to India, they'll go to the Indian-owned hospitals like Medihill, will actually go to India and get the doctors there, and then sometimes when they lobby and force the KMPDC to register these doctors, then they are housed in those particular facilities. This was happening in many of the hospitals. So, and in the essence, there's one thing they're trying to bypass, the wage. So if you are brought up as such, because of the way things are in India, they try to enforce that here. They will pay them lower wages. Sometimes they will go ahead as confiscating their license, their visas, their passports, so that they are actually more of a slaves within these facilities. And those are the ones who are being used to do all these manner of procedures, because then you don't have any, you act like this is your life, there's nothing else you can do. That's one thing. The other thing is that the doctors were being brought in so that they can bypass the CBA rates of paying wages, so that they are also in a lower terms and they have cheap labor. And therefore, we supported the statement of the minister that it is not justifiable that you ignore the doctors that exist in the country and to bring those from outside the country when we have those who can do these jobs, unless it's a speciality that we don't have as a country, that we can't provide. It does not make any sense to bring doctors from outside.
Is it an ethical question? Because if let's say I want to hire Dennis as a doctor, and I'm going to pay him, let's say, 200,000 a month, and I bring you from Tanzania, and your salary will be 50,000. If I go for you, you're doing the same thing, level of education, everything is the same. What really is the issue there?
It is both unethical, it's both injustice, it's also contravenes all the existing conventions that protects workers. If you look at ILO Convention 97, it says that if you are a skilled worker or a worker from anywhere in the world and you move to a different country, you should not be treated in any way less than those parts in those country. That is Convention 97. What Convention 100 says, if you are working in a same environment, doing the same job, you cannot be paid unequal wages. You have to be paid equally because you are producing the same services and the same job. So and Kenyan Labor Law, Labor Act 2007 says the same. So by the time that somebody is going to import a worker from outside the country and pay them wages, is a criminal and is violating all the existing laws. And therefore, and that's why we're talking about the UHC. By the time government is paying them less wages, it's violating its own law. So it's unethical. Yes.
Why do we operate? I mean, just looking at all of these things, why do we operate in a system of everlasting CBAs? That CBAs came into existence to say, okay, there was the group versus the government were not able to agree, right? And whether there was, you said at the beginning of this that all of this boils down to money and what's available and what people are willing to part with in order to make things happen. So we exist within a CBA between doctors and the government, exist in a CBA between clinical officials and the government, a CBA between nurses and the government, CBA, everywhere we look, there's a CBA. But then still with these CBAs, there are certain tenets of those CBAs which are not honored, they're not kept. From the last CBA, going into the next CBA, and then we seem to agree to enter into CBAs because it looks like a quick stopgap measure for the problem that we're currently facing, which is a strike. So there's a strike because we're not able to do 1, 2, 3. Let's have a CBA. Why do we keep accepting CBAs as modus operandi when it comes to these issues?
No, for record, government really fears signing CBA with healthcare workers.
Do they?
Yeah, and in the history of this country, the CBAs that have been signed with the civil servant unions, they've been signed with teachers, and they're never implemented. And it took KMPDU 100 days to actually get a CBA signed. The only CBA that has been signed in the health sector with the national government and all the 47 counties with the CBA between KMPDU and the government. That CBA, yes, was signed, but CBA remains useless and it does not make any sense to every worker if it is not implemented. And therefore, as a union, we made a very clear decision that we cannot engage into a new CBA negotiation or discussions without this CBA that we had being implemented. And that's why that was from the basis of the strike of 2024. And also there was a caveat whereby the existing CBA was being violated by the reduction of the wages of the intern doctors. Those are the things that took us to the streets. But as we speak today, there was an agreement that the CBA is being implemented. That is, the interns are getting the right wages as per the CBA in the first lot of it. And when the new lot, there's a proclamations on the same. The arrears that were owed to us for 7 years, in December and January, 50% was paid. And I think the new 50% has been put in the budgets for payment in July, August. So ideally, if that is paid as agreed, this will be the first CBA to be fully implemented in the history of this country.
Ever.
Because CBAs are always signed and agreed, but then you have to go on strike for another one where they can't implement and they ask you to negotiate a new one. That's something that we took note of and we did not agree to any negotiations.
So do they work then?
They work, but on a forced way. You know, if you don't force employers to implement CBAs as a unions, then you have no powers. You have no reason to exist. And therefore, that's why it boils down to strikes. And the moment workers strike, the moment we go on these strikes, that most of the time we say are strikes that are well brought about by the government. Why are we saying this? Because when you sign an agreement, and you sign a framework of implementing that agreement, and then you go put it in a closet and forget about it, you have meetings, you don't follow it up, you have court orders, you don't follow, then it forces the workers to then also down the tools because you've down your tool. And that's why we have those strikes. And these are the strikes for every other healthcare workers. They may not be having CBAs, but they have return to work agreement, they have engagement MOUs, they have things that you've agreed with employers. But employers are very quick to agree with workers. For example, in Kiambu County, where we've been having strike, and strike is still ongoing now, we had a strike work agreement signed last year on 8th of May 2024. We had another agreement signed in November. We had a conciliation agreed. So when we were going on strike, we had tried everything. So we had to just join the government on their strike. They ran to court. The court told them, this union has been here with us 5 times. I cannot suspend the doctor strike in Kiambu. The strike has to continue until there's a mutual agreement between the union and the employer.
Yeah.
Because for a long time, employers have been using the court to suspend strikes. They've been using the court not to run away from doing their job. But I think courts are smartening now and realizing, oh, this is consistent disregard to the welfare of the workers. Yes.
Davji, we have the universal healthcare, which is a great thing for the Republic of Kenya and for the citizens. If it works, the government is happy, the citizens are happy, and the doctors are happy. But for some weird reason, it's just not working. So, Kenyan who's listening to you right now and hearing you speak, how does it look? How grave is it? How bad or how good is it?
I think we need to have a lot of investment in the universal healthcare to actually see a reality of it and enjoy the fruits of it. I'm glad to say that, and it's being reported now, that there's improvement in the service delivery by the Social Health Authority vis-a-vis what it was a few months ago. There is need to have improvements in the drug deliveries and products to these particular hospitals. There's an actual need for the Kenya Kwanza government to implement the manifesto by employing health workers as promised in the manifesto, because they know that it needs health workers that are motivated to have these functional systems. There's need to weed out corruptions. I see the way ministry has started across board, from the ministries, from the counties, and then there's need to increase funding to this particular healthcare. With that, we can have hope that we'll get the universal healthcare, because the essence of universal healthcare is that if I am sick and I go to an hospital A, I don't need to go back and sell my land and get this care. I don't need to worry about the community to contribute for me to get the care. And that's why we believe that a time has come that we must also be part of this conversation. We must contribute to this conversation. And I said this last year, and I think I can still say this now, that the best way to castigate issues with Social Health Authority is to register and be part of it. Because then you will go to the hospital and see what service have I not gotten, or what package that we need to put in place. And then with that, you can actually challenge and improve the thing.
So this is what we're talking about, essentially, is that we can't say it is not working if we don't register for it and actually test this thing to see if it works. So we can be here, we can complain, and we can say, well, Dennis went to the hospital, so SHA is not working. Me, Ndu, is complaining because Dennis went and it's not working. But I have not had an engagement. I have not activated what I want to call right to complain because I have not registered for the thing. Also looking at, because it's a pool system, and it's not just in Kenya, it's a pool system. The NHS works on a pool system as well. All of these health systems that we've seen work on a pool system, that we take your contributions and we put them in one basket. And because we know that not everybody will go to hospital at the same time, that because you've made your contribution at one time or another, you will go to hospital, but you will then be banking on the resources that other people have put in. So what makes sense is that the more people register and make your payment, the more then it is available for you to have this service when you go to hospital. So what are we advocating here for, Daktari? Give them benefit of the doubt in the meantime. Everybody just register. Should you register and you then will not still be able to access, then that is a different conversation that we're having. But we can't complain if we don't register. Is that what we're saying?
No, what you're saying to Kenyans is that for this, to Social Health Authority, register. So that when you go to that hospital and you have a concern, you are able to say, fine, I went to this hospital. I needed to have a sedan section done. I needed to have this particular medication, but I was not given because of this and this issue. It becomes an easy way to solve the problem than when you perceive that things are not moving. For example, I have got complaints from people who say they've gone to the hospital And when they went to the hospital, out of a bill of 600,000, the social authority was paying for them 400,000. And then we ask, okay, if it's 400,000, why is it not paying for you the 200,000? Then the hospital will say the cost of us getting all these services is more than what you're being provided for. Then now we bring the conversation to social authority, tell them, okay, can we have a cost analysis between the hospital, the service providers, so that the costs that are going to be put as a package, then the patients don't need to pay more for that particular service.